Welcome back. Today we're going to be talking about side effects of treatment to the eye. We have two resident experts. I get to boast on them a little bit today. We have two of our local experts. We have Dr. Mihora, who is an oculoplastic surgeon with her own practice here, and she is actually the one who enucleated my eye. If you didn't know, I didn't have a real eye. And Margot over here, raising her hand, is also a voluntary I accept and tell you that I am a patient too. So we love Dr. Mihora, and we are so thankful for her to be here to chat with us about side effects of treatment to the eye. And just kind of some of the things that you can have done if you're experiencing some significant side effects that oculoplastics would help with. And then second, we're going to have ocularist Starla Allen, who is from the Eye Concern Ocular group. They're a local ocularist group who, if you don't know, an ocularist is someone who paints and creates the eye that goes in after you have your eye enucleated. They're also the ones who are responsible for things like scleral shells. And so she's going to talk about kind of how you can manage the side effects that come with having an enucleated eye and wearing a prosthesis. So, raise of hands, I just want to know who has a prosthesis and is comfortable saying that you have either a scleral shell or a prosthetic eye. So 1, 2, 3, 4, I count 4. Am I missing anyone? Okay, so there's 4 of us. So if for some reason the side effects of your brachytherapy one day lead to you losing your eye, just know we're all here, we're okay. We've figured it out, and you can too if you need to. And for anyone online, we just hope that this is a helpful session. So with that, I'm going to go ahead and bring Dr. Mihora up to the stage, and she's got a presentation for us. A round of applause. Thank you.
Well, thanks for having me. What a neat group and what a neat organization. The more I learn about it, this is my first time kind of coming here, but the more I learn about this is a really great thing to have. So again, thanks for letting me speak, and I'll take the first part, and then Starla will go in the second part. So I will say, I love just bringing some kind of humor into this, and I love eye jokes. So I just thought this cartoon, I don't take credit for it, but I like these. These make my nose look a little bit smaller. And I just think the anatomy of the eye and kind of what we can do to give back, some natural good function to the eye is a really big deal. A lot of times I'll hear the word cosmetic, is this cosmetic? And the answer is, yes and no. Yes, in the sense that we all want to be happy with our cosmesis, but no, in that giving back kind of normal, good, restorative function is functional as opposed to just cosmetic. So this is actually just a really neat skull. While you're hiking, while you're hiking in Belize, you can go see these just skulls after you dive through a puddle of water, swim through, come out the other side, but they're just everywhere. And just the natural skull and kind of the anatomy, I think, is just such a beautiful thing. So I have a couple slides to share, and we can go through any questions as they come up. Let's see. So this is not my main thing, but I just have to tell you, I was at a wedding the other day. Beautiful wedding, very emotional. I will say so emotional that even the cake was in tears. Did you get it? I love dad jokes. I know. While we're waiting. But it was interesting because the people who got married, they were actually two antenna. I know, antenna get married. And the wedding, it was okay. The reception, off the charts. That's all I got. We gotta get these slides going. So kind of what I'm going to talk about too is, when you get a prosthetic, when you have an enucleation, when you get a prosthetic eye, there are some things that can happen with the prosthesis. So inherently the prosthesis is a little bit heavier than an eyeball. So with gravity, and some of these changes we see just with time that we all get, but gravity might be accelerated a little bit with the prosthesis. So for example, some of the things that can happen with the prosthesis and some of the slides that I was going to show are an ectropion. So an ectropion is when the lower lid is pulled down just a little bit because of gravity. Again, can happen without a prosthesis, a very common thing we do in the clinic on a day-to-day basis, but because of the gravity or the weight of the prosthesis, it can accelerate that a little bit. Also, the socket has had some surgery, so some of the tendons or ligaments that hold the lid in place could be a little bit stretched out. And those are things that we can fix with a little tightening surgery. The tendon kind of anchors to the bone, so sometimes we'll need to tighten the tendon if it's become a little loose. In a socket or in an eye, if that tendon is loose and creating some pull of the lid, you can get a little bit of increased mucus, a little bit of increased irritation. We always start with teardrops, great lubrication, ointment, but again, if that tendon is truly pulled down, it can make the eye look a little bit different, but it can also create some other symptoms. And then just like the lower lid can be pulled down, creating an ectropion, the upper lid can have a little bit of heaviness. So a ptosis repair, if the shell, if the prosthesis isn't lifting the lid, can also be done to kind of lift that muscle and make it so that there's equal scleral show or appearance between the two eyes. And then other socket issues too. So socket or implant extrusion or infection is a concern that sometimes we'll have. All kinds of different implants can be put into the socket. So once the enucleation happens, we'll put in some sort of a ball, a spacer that both fills that space. Ideally, the muscles are attached to it so that it moves. Let's see, and these are some pictures.
So, Dr. Mihora, you should be able to navigate now.
Okay, thank you. So, I don't think is there a pointer on here? Yay, there is. Okay, and there's two screens, so I guess I'll use this screen. So this is showing some ectropion where you can see as the eyelid is closing, it's not quite closing all the way, that lid is pulled down. The tendon of the lower eyelid is normally attached to the bone there, and again, just because of normal gravity, normal weight, but also because of the weight of a prosthesis, sometimes we need to kind of tuck that tendon up a little bit so there's less show. And then ptosis over here, where you can see it just looks a little sunken, looks a little hollowed. So if we raise that lid, that can just give a more natural appearance as well. I think here I'm just showing some ectropion, I think. Okay. So again, when we remove the eye, that space, that socket needs to be filled. And there's all kinds of different implants. Silicone implants, acrylic implants, porous implants. And some of these have pros and cons to them. The porous implant really is a coral-like material where the body kind of grows into it. We grow neovascularization or blood vessels into porous implants. And muscles can be directly attached to that. However, if there's any concern down the road for infection or extrusion, and this picture here is a picture of extrusion where the conjunctiva has a little buttonhole in it, and we're seeing the implant. We worry that the normal flora then that lives on the eyelids and the eyelashes can get in there and create infection. And certainly we don't want that, because if infection happens, you can treat it with antibiotics, but sometimes that implant actually has to come out because we worry how far the infection has gone down. So unless there's something, and there's different, people feel differently about what to use, but unless there's something concerning where I'm worried about extrusion, for me, I tend to like the porous implants. Doesn't really matter. There's not a right or wrong. Also, the acrylic or the silicone ones are good. Sometimes with the muscles, though, we have to attach those two to each other rather than attaching them to the implant. One of the things that I guess I had the honor to do is I was through the military for my schooling, so a lot of my service time was in Iraq and Afghanistan, and unfortunately a lot of our enucleations or eviscerations there were traumatic. So this picture over here is actually, I can't remember if it's an Iraqi or Afghani, but there we tended not to use the porous implants. Number one, I'll be honest, they're a little more expensive and we didn't bring them with us. But also on the locals, they didn't have great nutrition, so we found the extrusion rate was really high. And this is actually an implant extruding. Granted, if the implant extruded over there, we would put in a piece of fat. So you can also just put in fat, and fat can actually fill a socket really well, and you can attach muscles to it as well. So in addition to all these options for the different implants, again, different materials, you can actually use fat, and there's nothing at all wrong with fat. In fact, fat is a great implant. So over there, we started to tend to do a lot of these fat grafts just because we're not worried about breakdown of that surface. But as long as there's, good nutrition and watching the scleral shell implant, these tend to do pretty well. And let's see. we have to look at this cartoon. So he just looks at the elephant with all the wrinkles, Botox. But so the other thing that can happen long term after an enucleation is sometimes just because of post-surgical changes, or if anything else is going on to the socket, it can kind of become enophthalmic, which means it's sunken back a little bit. And the fat, there's all kinds of fat back behind the eye. It's meant to be there. And the fat does go through some change, some atrophy, natural. I wish fat on other places of our body did that. I haven't figured that one out quite yet, but sometimes that happens. And so, I didn't mean to go there. Hit the red back, okay. Come on. Well, I may need some phone a friend, help from friends, but.
Ara, can you see if you can start the slideshow over again? Hit the click to exit and then start over.
Sorry.
Top of the screen, click to exit. There you go. Just go to that last slide again with the elephants.
The Botox.
There you go. It should let you go through now.
Okay.
Oh, no.
Oh, now we're at the end again.
Oh,
okay.
You got it.
So if enophthalmos happens, let me see if I can do this without forwarding again. So you can see there's a little bit of ptosis there, and this is a straight ahead photo as opposed to a side or 45 degree, but you can tell there's been a little bit of some, you see the sulcus a little bit more, that eye has sunk back a little bit. So there's things you can do for that too. This is a little sled implant where we can put a little sled implant up underneath the eye to kind of help bring that tissue forward a little bit and give more volume to it. You can also do fillers. Fillers we like for lips and other things, but you can put fillers there too to give some forward projection. So lots of options if that happens. Oh my gosh, I'm just shining past you. It's fine. I'm shining on day. This was actually pretty cool. This was a donation when I was in Virginia of our local ocularist to take over to Afghanistan or Iraq, just because a lot of these eyes didn't have any option for prostheses, and they weren't an exact match, but that was just kind of a neat donation over there. So really a lot of these side effects, can be mitigated. We can help with any of these eyelid changes, or if the eye starts to sink back. And a goal, again, it is part cosmetic, but it's also functional, because I think when this happens, if your eye is not looking as good as it can, there are things that we can do to make it look as natural as possible. So I don't want to steal any of Starla's time. I know she's got a good talk too, but I don't know if you want to do questions now or after. Or.
So I had a question about, I know you talked a little about, eyelids, scleral shells, and I've talked to, I think maybe two, I'm sure there's more of them, but two patients who had brachytherapy or proton beam therapy to the eye, and they now have a scleral shell. And it's kind of just helping to fill some of the space of this kind of slowly dying eye, right, from the radiation damage. They're already blind in the eye, but they still have their living eye. It just doesn't feel quite the time to enucleate. And actually, this is probably a little bit more of a question for the scleral shells for Starla, so I'm going to save that for her. But I was going to ask you, with brachytherapy, are there, kind of shrinkage and things that can happen? There's some people who say, my doctor told me to get an eyelid lift, or, something to that effect. And I would imagine that's something an oculoplastics surgeon would do. So enucleation aside, do you do a lot of those, and have you done those for uveal melanoma patients in your practice?
Sure, so great question. So kind of, radiation, brachytherapy, providing radiation to help shrink the tumor. Radiation has good effects, but also side effects, right? The good effects are, yay, we're shrinking this tumor, hip, hip, hooray. What else can it do in its wake? Well, it can change the surrounding normal tissues as well, kind of from the front to the back. So the front of the eye, the eyelid can get irritated. You can get kind of almost like an eczema or irritation where you're really needing to lubricate the eyelid. You can get some changes in the muscle to where it has a little bit of heaviness or droopiness, but that front surface, that conjunctiva that's meant to produce the good oil and the good tears, can get very well dried out to where we're needing to put in good lubrication to make it feel good. Yes, you can get some change in the aqueous fluid and the structure of the eye. You can get some calcium formation on the surface of the cornea, and that can be scraped if it needs to be scraped. Other medications, steroid medications, can help. So I would answer that and say there are a lot of changes really from front to back that can happen. but they are so individual, I think, and it depends kind of where the plaque is as far as what the most common surrounding area would be. It can also affect the muscle, where the muscle isn't moving quite as symmetrically to the other eye, so kind of from front to back. So, but yes, can be addressed.
Okay. Do we have a question, Shar?
So if post-radiation you're experiencing symptoms of discomfort, is that something that insurance would cover, any sort of treatment or surgery or anything afterward? Is that covered by insurance because it's caused by the radiation?
Yeah.
So for those in the virtual audience, the question was, if you're experiencing symptoms like discomfort, pain from the radiation and a surgical correction is deemed necessary, does insurance cover that?
Yeah, great question. And, I say that fight should definitely be fought, meaning if insurance is saying no, I would say, let's do an appeal, let's find out why not, because you're exactly right. This is caused by a medical condition. Treatment was necessary. And these are somewhat known side effects, if you will. I mean, dry eye or calcium formation on the cornea can certainly happen. So I think some of it, too, is making a plan for if it happens, what can happen, and if it happens, how do we target it? So I would say it absolutely should be covered by insurance, to the point where if it's not, I would fight a little bit and say, wait a second, why not? Let's get this covered.
Awesome. Any other questions from the audience for Dr. Mihora? Okay. Well, Dr. Mihora, thank you so much for being here. Thanks for your presentation. Starla, we'll bring you up. I think we've got your slides queued and ready to go. And we're going to go ahead, if there's no other questions for Dr. Mihora, we're going to go ahead and dismiss her. She's gotten a personal appointment that we're going to let her get to if she needs to. So good to see you.
Thank you for having
Guess we'll
me.
see you at the Scottsdale 5K.
I'll see you next year.
Yes. Thank you. Oh my goodness, Starla has a goodie bag. What's in the goodie bag?
Starla brought some visuals in case people
Well, this is
seen
awesome.
an eye.
Can I check and make sure your mic is on? Okay. Check, check, check. Can we turn Starla's mic up a tiny bit? Number one. Check, 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 check. Good.
Okay.
All right, so there's a clicker, and you should be able to navigate your slides. Can we go to full screen on the slides?
Okay, so right, left.
So green is going to take you forward.
Okay.
And it looks like you have a cool effect there. Here we go. Well, you just click,
Okay.
click, click until it...
I just know sometimes it wants to jump ahead, so. So I'm Starla Allen. I'm one of the ocularists at Eye Concern. And my slide is jumping ahead. So,
Okay.
just a second there. So I am one of the ocularists that you'd meet when you come to our office at Eye Concern. It's a family-run business, and there really is a difference when it comes to individualized ocular prosthetics. When you come into, not all eye makers are the same. In our office, we do the modified impression method, and we're board-certified ocularists, and that is someone that has, after all their regular schooling, has spent at least 5 years hands-on internship with a board-certified ocularist, learning the ins and outs of your anatomy, how to work with that tissue to actually get it to do some of the correction stuff that Dr. Mihora talked about, but also to give you the comfort that you're going to need. So if you are looking for a specific board-certified ocularist in your area and you're not in Arizona, there is a website that you can go to that we belong to a society called the American Society of Ocularists, and the online address is aso.org, and you can go on there and find a board-certified ocularist somewhere close to your area. There are not tons of us. We're very small, very specialized in what we do. At Eye Concern, we use that modified impression method, and when you first come in, we're going to talk to you about what's going on with your situation. We're going to look at your history. We're going to look at your socket. We're going to see the sensitivity that's going on there. We're going to see if your socket's healed enough, if you've had surgery, if it's healed enough to proceed with having a prosthesis made, or if you need a little bit more healing time. If you have a smaller eye, we're checking that sensitivity to see how your socket's doing, if it can handle having a shape in there, or if it's just too sensitive and can't handle anything in there. So we're going to look at all of that. Also, if you have had surgery, usually you come to see us about 6 to 8 weeks after you've had your surgery. Usually there's enough healing time that's taken place, the swelling's come down enough, and we can see what's actually going on with your socket and know where we need to go with your care. So once we know what your care is and how we're going to proceed, then we'll set you up for your eye appointments. And that's usually going to be 3 appointments that we have. And I was asked specifically to talk about several different situations. So whether you've had surgery and it's enucleated or eviscerated, whether you have a small shrunken eye and it's scleral, or whether you have a very small eye, an underdeveloped eye, or you were born without an eye. And we can work with all those situations. So if you've had surgery and had it enucleated, we're gonna look at your socket, see what's going on, and we can work with that. I'm gonna make this go backwards. My slides always wanna run faster. If you have which one's the pointer? This one. If you have the shrunken eye, or your eye's been damaged and it's starting to shrink, it might be unsightly, or it may be where, because of how the muscles are, it wants to look off, but you can't see, it doesn't want to ever come forward. We can also work with what's called a scleral shell and make you that goes over there. What that does is a scleral shell is going to fill up that space and help protect your natural eye as well as protect the socket and give you that appearance of a more natural looking eye again. Depending on your muscle movement with any of these situations will determine how much movement you have with your eye once we've made your prosthesis. Now this little girl, she has a smaller eye, it's an underdeveloped eye, and she was in the situation where we have to do what's called graduated conformers. And that's where we gradually increase the size of the shape that's in there so that it can gently stimulate the bone tissue and the socket tissue so that it starts to expand in that area so that their socket can eventually be able to hold a more natural size looking eye and be able to wear a prosthesis that looks more like their natural eye. Being able to do those graduated conformers is a plus for a lot of kids that are born without an eye and we're trying to develop their socket. Their surgeons generally send them to us first to see what we can do to help prevent them having to have surgery later. So if we can do that, it's a partnership with their parents as well as the patient, because it does take quite a bit of time because you have to work slowly with that tissue to get it to want to move naturally. So when you come in and you have your eye made and you're actually ready to have an eye made, it's usually 3 eye appointments is what we call it. And in our office, we do the modified impression method. So we're going to take an impression of your socket, and we're going to use that impression to see what your tissue looks like in the back, what your tissue looks like, how it's going to be moving, what we need to do with it, and then also be able to see what's happening overall. So we will take that impression, make a mold, we will pour wax into it, and then we have a wax shape. And that wax shape allows us to be able to fit the tissue that you have. So we'll put that into your socket, and we'll see if you have some of the side effects that you might get from losing your eye. You might have an upper or lower lid that wants to be really droopy and hang down. Well, we're going to create a shape to try and help bring those up so it looks more natural. You might have it where your the lid openings don't really want to open. Well, we're going to work with that wax shape to get that to be able to open more comfortably as well as naturally. We're also looking for the placement of where your gaze is going to be so that we can have it line up centeredly, as well as you might have scar tissue in there, or you might have ligaments in there that we need to work around so that it's as comfortable as possible and not causing pressure or pain in your socket. So those are all the things that the wax pattern allows us to be able to do when we modify it from the front to get that shape that's going to work best for you. Once we've done that shape and everything's done there, you're done with your first appointment with us, and we go and do behind the scene lab work and get that eye ready for you. And when you come back for your second appointment, that's when we have the painting time. And this is where a lot of the magic takes place. We Because we use a painting lens, it allows us to see what the eye is going to look like when it's finished. It allows us to put a fluid in behind so we can see the magnification. We can then put this eye into your socket during the painting process and be able to see how the shadowing is. If there's any different changes we need to make, we can capture all those little freckles that you might have in your iris, all those little unique characteristics that make it you. We're going to capture that and hand paint it and put it into this eye that we make for you, all the way down to your veining pattern and the white of your eyes. We capture it all. Once we've put it in near the end and you're happy with it and we're happy with it, then you're done, and we do some final things to seal that up, to make it ready for the final processing. We'll process it again, get it all cleaned up and ready for your third appointment where you come, and now we're going to teach you how to take care of this nice eye that we've made for you. We'll teach you how to put it in, how to take it out, what some of the care things are, things to look for, the fact that you are going to get discharge. That's a total normal thing to get, a little white discharge in the corner. It's your body trying to produce some kind of lubrication. And if you're using lubricating eye drops underneath your upper lid, that's going to help cut down on that discharge. It also helps to keep that socket nice and moist so that you have more movement, so that your lid's not sticking, and so that you have more comfort. So lubrication is something that you will have to do throughout the rest of your life once you've damaged your eye or had it removed. And you'd want to make sure that it's a lubricating eye drop. So those are some of the things that you would get, that you'd learn from us when you come in. We would also talk about the fact that your tissue changes over time. Once you have a prosthesis, it's not a lifetime piece that you're going to have. You're going to need one for a lifetime, but this one is not going to last you for a lifetime because your tissue changes and so does your eye coloring. And so we suggest having a new one made every 5 to 7 years because of all those tissue changes and because of the natural eye color changing, as well as it's a porous material, so your body fluids start to get in there and break things down. People like around 10 years will start to have more irritation quicker. They might be getting infections a little bit quicker, different things. So not going past that 10-year mark is an important thing. And when you come in to see us, we do have you come in. In Arizona, we have found that right around 6 months is normally when people are like, okay, it's starting to bother me. I'm getting more irritation. The weather's starting to irritate me. So around 6 months to a year, people come in and they have us clean and polish the eyes, as well as check their sockets to make sure everything's looking okay. We check to the alignment of the eye, make sure everything's looking good there. You are going to develop some space, and so some people develop it faster than others, especially with children. And so we do what's called a refit. We tighten things up so that it's more secure in there again. If your prosthesis is feeling loose, then you might have that feeling of, oh, I feel like it's going to fall out at any moment. We don't want you to have that feeling. You might feel like it turned or it's not staying in place. Again, that's tissue changes that are taking place in your socket. So you'd come in and we would tighten things up a little bit, add some material to it, again, fitting to your individual socket so that it fits you nicely. If you have an ill-fitting prosthesis, you're not going to be a happy camper. It shifts around, it could fall out easily, it could cause irritation with the tissue, it could also cause some damage with your socket. So making sure that you have a well-fitted prosthesis is really important. So this picture just kind of shows you a variety of different things you might see down in the corner. These are some graduated conformers right here. It could be for a child that had an underdeveloped socket and we're gradually working up until they can wear something more natural sized. It could be a older person where their socket shrunk and contracted and we're trying to recreate that space again and working with their tissue. As you can see, there's all different shapes and sizes of eyes. This is one where a person, their upper lid, the way that they had lost their eye, the lid had been cut in a car accident, and so that upper lid would not come up. The muscle was cut. So we built a shelf on it so that that upper lid can sit on it and it looks more natural. And that's a situation where most definitely they'd have to be lubricating because the eye is not going to blink as much. It's not going to cover the whole lid. You can see from several of these, with their companion eye, they've surgically had their pupil changed because of medical reasons, and so we duplicated that in their prosthesis. We've had it where there's contacts that they wanted to be duplicated on it. We will do that. The shapes are all different because each of you is different. Every single one of you is unique, and so is your socket. And so we make everything custom for the person that comes in. And we wanted to make sure that you're comfortable with looking at you, as well as how your eye's fitting. Any questions?
So I have a question. You talked a little about scleral shells, and I know, like we said, we pointed out there's 4 of us, I think, in this room who've had an eye enucleated. And so, of course, we've got the extra lubrication. So I guess maybe to touch on that, just for anyone who does have an enucleated eye or who has, I know we also have members of our community who unfortunately are unable to wear a prosthesis for one reason or another. Just, there's a lot of different reasons that can happen. I'm sure you know. Maybe repeat infections. I'm trying to think what other scenarios might be.
Sometimes their socket sensitivity is
just
too
the
much.
socket sensitivity. But so I guess first, what are some of the lubricants that you suggest to people who do have either a scleral shell or a prosthesis that fits well in their socket to help lubricate that upper lid and make it more comfortable?
So usually if you look at your bottle and it says it's a lubricating eye drop, stay away from Visine. Visine's for redness. Like the brand itself is mainly for redness, but it's got to say lubricating eye drop on it. It's not your medications that you're getting from your doctor. If you're taking a medicated drop, that's not a lubricating drop. So don't just avoid your lubricating drop because you're like, well, I'm putting a liquid in that counts. There is a specific drop that's made for prosthetic eyes. It's called Solaptho. You can find it on our website. You can find it in a few other places. You will not find it at a store. It's not prescription, but you won't find it at a store because the stores can only sell what can be put into both eyes naturally. Solaptho is an oil, and it's only for your prosthetic eye. If you put it in your good eye, you're going to have some stinging and burning and not be a happy camper for a little while. It's not going to damage you, but it's not going to be a happy moment. So Solaptho is an oil-based drop that's specifically for prosthesis. You can use a salve. There's Lubrifresh PM, Retain. There's several different salves. Most stores will have a store brand. It will have the same ingredients as the name brand ones, but in a different order and amounts. And so usually if you can get a brand name, that's better than the store ones. But yeah, lubricating eye drops is what you want.
Okay. So, I know just from my personal experience, just working with the dryness, working with trying to figure this out, by raise of hands, anyone who's had dryness, how many of you have had to experiment with your eye drops? Just show me in the room. Anyone who's had to experiment and kind of touch and go to figure out which eye drops work for you today. Okay. Is there, I guess, and I think I see Dr. Mihora in the back, is there a reason for that? Why maybe if, I don't know, say March, eye drop A works and then come May it doesn't? Or, do we have a scientific reason for why that happens?
Some of it's your individual body and your makeup of what your body's going through. It could be medications or other drops that you're using that can also affect it. Allergies, the amount of water intake that you're taking can also affect how dry your socket's getting and what drops work, what ones aren't right then. And a lot of people don't realize that if they have dry eye syndrome on their natural, their good side, their companion eye, it's on that side too. So just because you may not have all the same symptoms on your prosthetic side does not mean that it doesn't need lubrication. You still want to be lubricating that side as much.
Yeah, I know, it also changes, I think, time of year, rainy days versus humidity, no humidity. In the desert here in Arizona, I know, I feel like it's literally every couple months that I'm like, oh, look, it feels different today, yay. And so I just, hope that we can encourage anyone listening that if you are trying to find the right kinds of eye drops, whether your eye's been enucleated or not, just keep trying because there's a lot out there. Just also disclaimer, be safe. And if any have recalls, I think in the last year or so,
right,
we've had some significant recalls from the USDA or the FDA. I don't know where they did the recalls, but they were saying they were causing infection. So just please be aware and watch for those kinds of things. Talk to your retina specialist, your ocular oncologist, anyone you see for regular eye care. Make sure that you know if there are any present recalls on eye drops because some of them preservative free or otherwise do get recalled periodically for contamination, various things. And especially if you're someone like me or you have limited vision in one eye and good vision in the other, you want to protect your well-seeing eye as much as possible.
Yes, most definitely. You don't have a spare anymore. Protect.
You don't have a spare.
Protect.
Okay, so wait, speaking of that, you guys talked to me about this, and I'm one of those people who wears glasses already. Like, I need a prescription to see. Like, guys, I can't see you. You guys have recommended, I think, just in the office to just wear glasses regardless if you have a prosthetic eye. Is that, like, just a safety thing?
So not everybody needs to. It's something where if you're one of those people that's more active and you're around areas where more particles can get at you, then just wearing safety lenses is a very good idea. So we have lots of kids that they don't need a prescription glasses, but they wear glasses that just have a protective lens in there. If they're in sports and they do need glasses, then we suggest they wear athletic eyewear because of the fact that elbow coming or different things, we just want them to be a little bit more extra protected. But you are doing things in your daily life where, construction workers, different things, working with wood, working even with us when we're cutting away at the eye and there's materials coming at it, we'll wear safety goggles of any type. But you're living your daily life. There's things coming at you constantly that you don't know. You could be, and we have had people come in where they lost their eye due to a thorn from a fruit tree and they didn't get it out soon enough, or different things. You could be out picking or whatever. If you had those lenses on, it would just give a little bit more safety to your natural eye your seeing eye that you still have. Yeah. We just want you to be protective and proactive of that since you don't have a spare.
Okay, awesome. Well, thank you. And I know the other reason that I think Trent talked to me about this, the other reason he suggested that I wear my glasses at least is to help kind of disguise some of the differences, at least between wearing a prosthesis or a scleral shell and your natural eye, especially if you have limited movement or things like that. And I guess we don't have someone who could speak to why like a lens is balanced, right? But so people always ask me, do you have the same prescription in both eyes, even though you can only see from one? And the answer is yes, because if I didn't, one would be way more magnified than the other, and we would not want that appearance-wise. That would look really wonky.
So there are situations where because of how the lids are, they're opening, and again, how they had lost their eye, we can only do so much. We can work with your socket as far as it can. There's sometimes you're going to have to go back for surgery to be able to do a few other things that we were not able to do with the eye. But there are other situations where they made it because of how they lost their eye, there's more damage. And to help either give that illusion of the eye being a little bit more closed or a little bit more open, we can tell them, okay, try this type of diopter in your lenses. Have them put this type in there so that it magnifies or shrinks that size so it looks more natural to your other side. But if you do have a prescription and you don't need any of those extra things, then making sure that you have the same prescription on both sides will draw less attention to your prosthesis. Also, there are some people that will wear the bigger glasses because maybe they were kicked by a horse, maybe, and they've got scarring that's taking place. So those lenses help hide some of that so that it doesn't draw as much attention as well.
Okay. Anybody have any other questions for Starla?
Yes.
Carrie?
My eye was enucleated in 2016, so I've not worn a prosthetic, although a scleral shell was made for me, and I was never able to do it with a lot of reasons, and then financially. But the question I have then is, do you recommend drops to keep infections at bay, and do you recommend like cortisone drops in eyes?
Okay, so the question was if you have an enucleated socket, correct? Like where you have an eye that has been enucleated, you don't currently have a prosthesis, you're not wearing one for whatever reason. Does Starla recommend prescription like antibiotic type drops regularly to prevent infection of the socket and also a steroid like cortisol drop?
So when it comes to prescription type stuff, I would have to turn it over to Dr. Mihora, but for just lubricating and protecting, using a lubricating drop in there, again, is still going to help to keep that socket healthy and help to keep things so that it's moving comfortably. Having it covered with something, whether it's a patch or a conformer and there is something just to help keep from particles getting in there, the air getting in there and really drying it out and irritating. When it comes to infections, Dr. Mihora, would you suggest that they
feel free, come back up.
Anything that comes to prescriptions, I turn it over to the doctor.
Check.
Well, so first thing I'll reiterate is just the importance of, lubrications. And if you look at the teardrop, so a tear that our eyes makes, the bottom 5% of tears are mucin or mucus, the conjunctiva makes that. Then about, 90% of the tears are water. Top layer of tears are oil. Prevent evaporation, put oil on top of water, doesn't evaporate as well. So just going back to that question of what type of tears should I use? So there's so much new stuff with tears that's exciting, and it kind of depends what level of your tear drop is compromised, shall we say. So some of them give back more oil, some of them help with the mucus layer, some help more water, some have more hyaluron in it, which is the spreadability. So first thing I'd echo is just the importance of tears to prevent some of these things. Now granted, if the socket is getting infected, the question is why? And most commonly, or the thing to rule out, is that it's not an extrusion, again, where that conjunctival layer is breaking down and we're getting infection. I tend to not do preventive antibiotics, but more so general prevention with teardrops, that kind of thing, looking at the eyelashes. Eyelashes have a lot of, fun stuff that can live on it. Bacteria, mites, believe it or not. You can see mites sometimes, and that they're normal. I mean, well, they're normal in the sense of you can see them, and so it's kind of what's causing the irritation or the infection. Same thing with the steroid is, well, why are we getting inflammation? Is it because of allergies and we need to treat the allergies? So I would say great question, but I'd prefer to prevent rather than treat, but sometimes you do need an antibiotic or sometimes you do need a cortisone drop for inflammation. But ideally, if we can prevent that, then even better.
So I guess it also just sounds like if you are someone who's experiencing a need for those kinds of things, right, where you're being told, oh yeah, like I need to be prescribed antibiotic drops, or I always need steroids, that's a sign that you should probably go see an oculoplastic surgeon. You should go see, who would be another person who would evaluate that? Is it just oculoplastics?
Well, I mean, really, I'd like to think anyone in our eye team could. That being said, some people are better at treating the socket than others.
But it's like if it's a repeat issue, it probably needs to be addressed as a real issue that is, something is going on causing you to need those prescriptions. And hopefully if that could be addressed, you would no longer need the prescription.
Correct. So whether you're, regular eye doctor or optometrist or ophthalmologist could, just like you have a society, we do as well, which is asoppers.org, American Society of Ophthalmic Plastic Reconstructive. So it's a possibility too to find somebody that way.
Awesome. Thank you so much. Anybody else have questions from the audience?
What about the wipes? We get the wipes.
The discharge?
The lid wipes.
Oh, the lid wipes. Oh, well, okay, yeah. What are lid wipes for, and why do we need to know about them if we have eye irritation?
Okay.
It's just, here in Arizona, you get a blow dryer effect, and so
Yeah.
Right. So one of the things is she was asking about little wipes that you can get to help clean your lids and lashes. If you are getting, like in Arizona, okay, I can't talk California, some of those other places, but Arizona, we are so dry and windy and dusty. And so there are times where allergies are going to kick up and you're going to get a lot more discharge, a lot more sticking to the lids and everything. You can use a warm compress to clean your lids and lashes, but if you're not around that, there are lid scrubs from OcuSoft that you can get. They're at the store or they're at your ocularist office. You can look at them online, but there's a couple of different varieties and you can just use those to gently set on your eyelid so that it can break up that material and then gently wipe it off so that you can clean your lids and lashes. And there is one there that's also for if you happen to have lovely things growing on your eyelashes or hanging out there. You can use one that's for mites or things like that. But there's one for allergies, there's one just for normal care. You don't have to wash it off afterwards, but those are something that you can keep in your pocket, in your purse, in your briefcase, and just take with you wherever.
I feel like we're all going to have nightmares about eyelash mites now, you guys. I'm like, I've never heard of this, and now that's going to be all I dream about. I'm horrified.
We're trying not
just
to
in time
scare
for
you,
Halloween, but also like, all right. Well, thank you so much, Dr. Mihora, for being here and for your presentation. Oh, we have one more question.
Yes.
One more question for Dr. Mihora. This eye, like the lid's droopy and the eyebrow works really hard to keep it open, so my face is always wonky. Is there like physical therapy?
Okay, good question. So is there physical therapy?
Other than surgery? 'Cause I
Yeah.
feel wonky that hurt.
So basically, the main question for those of you in our digital audience, the main question is there, if I have radiated eye, right? You still have your eye. Maybe you can see, maybe you can't, but you still have your eye. You're not to enucleation, so you're not to Starla yet. You're not even to surgery fully for like enucleation. Is there something you can do before any kind of an eyelid lift or steroids, shots, anything? Is there something you can do to prevent needing the surgery for like an eyelid lift?
Yeah, great question. And symmetry is really the goal, part of it, as far as what you're asking. We want symmetrical. We don't want to have one eyebrow pulling up. And some of that is because we're trying to lift. So the levator muscle, the muscle that lifts the eye, if it's not coming up, our frontalis in the brow tries to contract. It's really hard to get that muscle to stop. In fact, even in people who have two seeing eyes, where we lift one eye, you can see now. You don't need to lift it. If it's been lifting for years, it's hard to get it to stop. Now, you can outsmart it in the sense of, sure, you could put some Botox up there and, well, eventually I'm going to stop lifting it because I can't. You can continually tell yourself, like a physical therapy, or put tape on it to help, but it's a natural muscle that really is learned to pull and lift. So yes, you can do physical therapy, but it's a constant thing. I'd say the outsmart way would be put Botox in, see if that stops. It's not, surgery, but of course Botox wears off too, or some sort of neuromodulator. So yes.
Well, I think you look beautiful from here. You look awesome. So, all right. Well, thank you guys. Thank you guys for your feedback. If you guys have any other questions, and also Starla has some really new cool visuals. So Starla, if anyone wants to hang out for a couple minutes on the break to see what you've got, can they just find you in the lobby?